Good afternoon, everyone. My name is Luis Fernando Guimarães. I am a neurologist at Hospital Federal de Servidores from Rio de Janeiro. I will talk about can MS and MOG disease coexist. I hope that at the end of this lecture, each person can answer this question. Myelin oligodendrocyte glycoprotein is a component of myelin expressed exclusively in myelin produced by oligodendrocyte and the central nervous system. It makes up less than 0.05% of total myelin proteins and identified 40 years ago. About the antibody against MOG, they were detected nearly 30 years ago. In the past, it was understood that this antibody could be a specific protein responsible to develop demyelination of multiple sclerosis, and the first methods for detecting antibodies against MOG were very sensitive and non-specific. Along the time, we discovered that these antibodies can be found in low titers in the general population and do not cause disease. Today, looking back, we understand that the sensitivity of the first tests was high and the specific is low. Normal people with low MOG titers and without disease were positive when they were investigated with these first methods. When we start using CBA and improve its technical analysis, we improve the accuracy and found more accurate results. So here we see few patients with MS that have positive results to MOG antibody. In 2016, MOG disease was classified as atypical demyelination, and MOG antibody was a high specificity and can be used to define a non-MS demyelinating disease in adults and children. Understand that it was not a specific antibody for multiple sclerosis. It was studied in other contexts, NMO, AKP4 negative. And some studies show that up to 42% of NMO AKP4 negative are positive for MOG antibodies. In the past, Madden et al. In 2011 studied NMO population with negative AKP4, and after this other neurologist reproduced her work. In Brazil, for example, the study population was composed by adult patients from Rio de Janeiro with inflammatory demyelinating disease, new and old case, show that in this study, only one patient among 5 patients with inflammatory demyelination disease was positive. Among the patients that have NMO and were negative to AKP4, only 2 were positive to MOG disease. Maybe the study was, of course, this study was done with CPA, and maybe this can suggest a racial influence. So today we have the knowledge that the relapse happen in 93% of patients with 8 years disease duration. Optical neurite bilateral happen in 51%, and optical neurites and myelitis together in 18% of patients. ADEN is the most frequent anti-MOG syndrome in children. Bilateral or recurrent optical neurite are the most frequent anti-MOG syndromes in adults. Here, 2 graphics. The first compares 61 studies using CBA or immunoprecipitation, showing more children positive for MOG antibody. in 10 adults. And on the right, this graphic show with increase of age that the clinical phenotype associated with MOG antibody changes from Adam form to optical spinal phenotype form. About MRI, during optical neuritis attacks, orbital MRI show extensive optical nerve T2 hyperintense, and this involvement usually affects the anterior segments of the optical nerve. Inflammation and enhancement of the perioptical nerves is often demonstrated on the optical nerve involvement is bilateral in 5% of cases. Heterogeneous enhancement with blurred margins, cloud-like enhancement is generally noted. Well-defined nodular enhancement or meningeal enhancement is also occasionally found. A bright spot lesion and intramedullary lesion with a high T2 signal intensity and CSF. And one of the most relevant radiological findings described was the presence of hyperintensity H-shaped signals seen in axial sequence. Despite all this, we know that there will always be a characteristic case of multiple sclerosis that will be surprisingly shown as MOG. Since medicine is not an exact science like this case, as well as there will be patients, AKP4 positive, that fulfill McDonald 2017 criteria. So today, the most line of treatment of MOG use corticosteroid and plasma exchange to treat outbreak and other drugs like rituximab as preventive treatment. Drugs such as interferons and glutathione acetate appear to inefficacy. And to end, I have the first question with another possible question. Is a new classification necessary based mainly on biological criteria such as antibody states? So my reference, thank you.